A male in his 60s with no previous medical history presents to the emergency department with acute breathlessness. A chest x-ray is performed and doesn't show a cause for the dyspnea. He goes on to have a CT pulmonary angiogram looking for a pulmonary embolism. What's the diagnosis? Let's go through the case. Here we have a CTpa, which is the gold standard test for pulmonary embolism, and with PE a worldwide killer, this is something that's being performed more and more all over the world. But how do we get the images? Ideally, a 20 gauge cannula is needed with a large caliber vein to achieve a contrast flow rate of at least 3 milliliters per second. Here we've got good opacification of the pulmonary arteries. Here is the pulmonary trunk, and these are the right and left main pulmonary arteries. Our job as a radiologist is to follow the pulmonary arteries out into the lungs and see if there are any filling defects that could represent a PE. On this scan there is some breathing artifact at the lung bases, but otherwise the pulmonary arteries look normal, so we're not thinking about a pulmonary embolism. However, let's have a look at the heart. Now this is a CTpa study where we're focusing on the right side of the heart and the pulmonary arteries. However, we can just about make out the left ventricle. Now remember, the left ventricle handles a high pressure system, so its wall is thicker than the right, which helps us recognise it. The left ventricle appears dilated. If you're not sure, measure an internal diameter on an axial CT slice. Anything over 5.5 centimeters, and you can be pretty sure the patient has left ventricular dilatation, as this has been seen to correlate well with cardiac MRI and echo-defined LV dilatation. Now let's have a look on lung windows. Now the lung is made up of secondary pulmonary lobules. These are considered to be a fundamental unit of lung structure. Each of these has a distal pulmonary artery, bronchiole, and multiple acini. Each lobule is outlined by interlobular septae, made up of connective tissue and contain pulmonary veins and lymphatics, and are hexagonal or polygonal in shape. When these are thickened, we can see them on CT, like we can here. Now there are a few causes for this, but by far the most common for smooth interlobular septal thickening is pulmonary edema. Other things can do it. Notably, nodular interlobular septal thickening can be seen in cases of lymphangitis carcinomatosis. Further down, we can see areas of groundglass opacity. Now putting all of this together, although there is no PE to account for the breathlessness, the interlobular septal thickening and groundglass opacity are likely signs of pulmonary edema. Interestingly, we can see these findings were difficult to elicit on the preceding chest x-ray. The pulmonary edema is likely to be cardiogenic, given the left ventricular dilatation, which was subsequently confirmed on echo. So what are the common causes of left ventricular dysfunction? The list is long, however the most common cause is also the biggest cause of mortality in the world: ischemic heart disease. Other common causes include hypertensive heart disease, valvular heart disease, and arrhythmias. So once we know there is left ventricular dysfunction, it's now important to investigate for ischemic heart disease. The patient went on to have a cardiac CT, which is a non-invasive way of assessing the coronary arteries. Here we can see the left main stem arising from the aorta above the left coronary cusp of the aortic valve. In normal circumstances, this divides into two. Into the left anterior descending artery, which travels between the left and right ventricle within the interventricular groove, and into the left circumflex artery, which travels between the left atrium and ventricle within the left atrioventricular groove. We can see calcified plaque within the LAD causing mild stenosis, but nothing that would be flow limiting as to cause left ventricular dysfunction. Here we have the right coronary artery, which again has some calcified plaque, but again isn't flow limiting. This all suggests ischemic heart disease is not the cause of the left ventricular dysfunction. Workup for these patients can include a cardiac MRI, and here, like an echo, we can look at the function of the left ventricle. On this 4-chamber view, we can see there is a poor left ventricular ejection fraction. Where cardiac MRI really comes into its own is by tissue characterization with the use of gadolinium. This can help us differentiate between ischemic and non-ischemic left ventricular cardiomyopathy, and also help us differentiate between different non-ischemic causes. We start by injecting gadolinium, which we know accumulates in the extracellular space. Now in pathologies that cause myocyte necrosis or fibrosis, such as infarction, there is increased extracellular space and increased gadolinium. So what we can do is choose a timing of the scan where the myocardium becomes nulled or black, so-called late gadolinium images. Accumulation of gadolinium causes T1 shortening, and relative to the null myocardium will look bright. So how can we distinguish between ischemic and non-ischemic late gadolinium enhancement? We can split the myocardium into 3 parts: the subendocardial layer, which is the inner part, the mid-wall, and the epicardial layer, which is the outer part. Put simply, in ischemic heart disease, the coronaries become blocked, and the subendocardial part of the wall is affected first, as this is most vulnerable. and then it spreads to involve the mid-wall and then the whole wall, so-called transmural involvement, whereas non-ischemic causes of late gadolinium enhancement, such as other cardiomyopathies and myocarditis, affect the mid or outer wall and spare the subendocardial layer. Here we have a short-axis late gadolinium image at the level of the basal third of the left ventricle. Here we can see there is linear late gadolinium enhancement here within the lateral wall, and possibly some more within the septal wall as well. Now this is the mid-wall layer, and not subendocardial enhancement, which you would have expected in ischemic heart disease. Linear mid-wall enhancement can be seen in a dilated cardiomyopathy, although most commonly affects the septal wall alone. CTpa scans are done more and more these days, and although it's important to look for pulmonary emboli, we need to be on the lookout for other causes of breathlessness. Remember, the most common cause of smooth interlobular septal thickening is pulmonary edema, and always have a look at the left ventricle on CT.